All right, terrific. Hello again. So David Chang and I are going to present some topics, and I think since my three are in a row, I'll go ahead and present all three, and then I'll pass the microphone over to David. So my first two talks I'm going to lump together because it's very related to each other, and I'm going to talk a little bit about how to select a refractive IOL and make it a stepwise approach. So the disclosures have already seen. So I think that we've talked a lot about refractive surgery and choosing the IOL. So how do you choose the patient and the IOL, and how do you put it together? So a couple really basic points, and those who do a lot of refractive surgery already know this, but those who do not do a lot of corneal refractive surgery, just remember that all the testing has to be done before the drop. So before the pressure is tested, before the dilation, and if they're a contact lens wearer, I always take out the soft contact lenses 2 weeks prior to the test. And if they're a rigid gas permeable lens wearer, I take them out a month per decade of use for the rigid gas permeable. So quite a long time. And I always have all the testing done before I see the patient so that I have all the information in front of me so that I can talk to them a lot about what their eyes look like and what lens may be the best for them. I tend to do 4 different measurements of the corneal curvature. I have a non-contact biometry either with an IOL master or lens star. I do Ks by auto and manual methods. I do a topography, and then I also do a macular OCT on every patient. So here's the decision tree. So first, the most important is the state of the eye. Is it healthy or is it not healthy? What do I mean by that? So I look at every part of the important parts of the eye. So look at the cornea. Do they have anterior basement membrane dystrophy? Do they have endothelial disease? Is their topography irregular? Is there scarring on the cornea? So all those factors come into play when you're choosing the type of lens. Look at the macula. Do they have a healthy macula? Is there epiretinal membrane? Is there AMD? Is there diabetic retinopathy? Is there retinopathy of any kind? And then neuro-ophthalmology is also important. Do they wear prisms in their glasses? Do they have strabismus? And then glaucoma. Is their glaucoma very mild or is it very severe and end stage? So again, looking at the health of the eye, I believe, is very, very important because that leads you down a different path. So is it healthy versus not healthy? So first, if it's healthy, then I look at the amount of astigmatism. So now I'm going down the astigmatism path. So I look at the amount of astigmatism, and my cutoff, again, it's just personal, is I look at about a 1.5 diopter. If it's greater than 1.5 diopter, I'm already thinking toric for this patient. If it's less than 1.5 diopter, I'm going down a different pathway. So let's go down. So first, when we talk about a toric IOL for patients who have more astigmatism, when do you not use a toric IOL? So I think there are a couple instances. Usually toric IOLs are fairly easy to use. They're very forgiving, and most people can tolerate a toric IOL very well. But I think the biggest category is to avoid is when their cornea is not stable. So their corneas are progressively going to change. Whether they have keratoconus, whether they have pellucid, something is going to change that I'm more wary of putting in something that's permanently going to be in their eye that I cannot correct very readily. So in a younger patient and their corneas are going to change, I will choose not to put in a toric lens. However, if they're an older patient, specifically if they've been wearing spectacles, they're not contact lens dependent for their vision, they've been pretty happy with correcting their irregular cornea with a regular pair of glasses, then I know that that patient will probably do just fine with a toric intraocular lens. However, if they have always been contact lens dependent, then I tend not to put in a toric lens because I know that it's going to be much more difficult to correct their astigmatism if I've already put in a toric intraocular lens into their eye. Also, if they have a very abnormal eye, they have very severe zonular abnormalities, the bag may be unstable, the toric lens may shift later on. So step number 3, does the patient want to be spectacle independent? And a lot of people say, you know, doctor, I've been wearing glasses forever. I like glasses. They cover the bags under my eyes. And so they tend to want to just keep glasses, and that's fine. But in those patients who want to be spectacle independent, then that breaks again down to a different decision distance. Are they okay with wearing glasses, or do they want to be independent of their spectacles? And if they want to be independent of their spectacles, then I'm thinking, should they have monovision, should they have accommodating, or should they have a multifocal lens? So step number 4, I look at their current refraction. So is the patient myopic, hyperopic? Do they currently use monovision, or do they have prisms? Those are the things that I'm looking at. If they have monovision, I tend to just oftentimes keep them with monovision. Those people have always proven that they like one distance, one near. They don't mind the fact that they're losing the three-dimensional vision. So those patients I keep with monovision. So in terms of multifocal versus accommodating, again, the factors to consider is besides, is it healthy? What are their expectations? Are their expectations too high? Do they think that they're going to get everything and not be able to use glasses for anything? Or do they understand the problems? Do they understand that there is a compromise with these lenses? And the fact with accommodating lenses is that there's an unpredictability. You don't know whether they're actually going to get any type of uncorrected near vision. They can also end up myopic or hyperopic even for distance vision. So there is a bit of unpredictability with accommodating lenses. In terms of patient selection, I know that David is going to talk about this in detail, so I'm not going to spend too much time in terms of talking about the corneal surface, but specifically I think it's very, very important to look at the gross factors of the cornea. So how dry is their eye, how is their surface, the blepharitis, but also smaller nuances looking at their higher order aberration. Everyone talks about coma. I think trefoil is also important to look at. I use a NIDAC OPD scan. I don't have any financial interest in this. I just want to share a couple slides. With this particular machine, there's this IOL decision tree that's very, very helpful. And so it goes through a little bit. I've written down the steps that I look at. Number one, it's a topography. So I look at the Placido disc image and I look to see if their cornea is nice and smooth. It can also look for angle kappa. So we know that the angle kappa should be 0.43 or less. It looks at the corneal astigmatism. It shows whether it's regular or irregular. It also tells you how much there is. And then it also tells you the higher order aberration. So it tells you how much is in the cornea, how much is in the overall eye. So it breaks it down into the cornea versus the overall eye. And then it also tells you about the pupil size. So it gives you a lot of information just from one screen. This is a wavefront summary. Again, David Chang is going to talk about this, but this also gives you a nice Zernike graph. It tells you which of the higher order aberrations is in what quantity and whether or not this is too much or too little. If we're talking about a presbyopia correcting lens, we talked about which eye to do first. Again, I like to do the non-dominant eye first. If they're happy, put it in the same eye. If they're not, and you have to figure out why. Number one is usually the residual refractive error. Sometimes they just need both eyes. And the way you can determine whether they just need both eyes, that bilateral summation that people talk about, is that if they're actually seeing well in the first eye, they may not be thrilled, they're not happy, they're not jumping up and down, but they're seeing well. They're reading J1 or better. They're seeing distance very well. It's just that together they're not using their eyes together, so they're unhappy. Then in those patients, I still put in the second eye because I know that they're actually seeing well. However, if they're not seeing well, they're 20/40, for example, and I can't get them to 20/20, then I don't put it in the second eye. The other situation is patients who are myopic preoperatively, around a -3, for example. Because I work on the non-dominant eye first, sometimes their dominant eye, the myopic eye, is still very dominant, and their brain is suppressing the new multifocal vision, and therefore they may not notice that they're actually seeing well out of the multifocal eye. If they have the final category, which is that poor quality of vision, those are the most troublesome patients. So in those patients, they complain that their vision isn't very sharp. Those are the patients that I won't put in a multifocal in the second eye. We did a little study. This is non-published at this point, but we looked at all the unhappy patients. So we looked at all the patients who came to us, either my own unhappy patients or people who were referred to me who are unhappy. And we looked at all the different combinations where they were multifocal, monofocal, multifocal, accommodating, all the different combinations. And we found that of all the 100% that were unhappy, if we ended up choosing the other second lens based on what the problems were with the first eye, so for example, if they had a multifocal eye, they were unhappy, then we put in an accommodating lens, then 95% of those patients were actually happy with that second lens. So what that taught us was that even if you have a very, very unhappy patient, 95% of the time you're going to make them happy by changing the type of lens. So I think that that's a nice way to be able to sleep at night if you offer a lot of these technologies. couple little techniques to make sure that you're optimizing a multifocal patient is make sure you're operating under topical anesthesia. I think using a block, you can't center the multifocal as well. You want to make sure that you have them look up at the microscope light to center within the innermost ring of the multifocal lens. And I think that preoperative counseling, patients who have pseudoexfoliation, those types of patients, you have to make sure that they understand the risks long term. This is something that I learned from Andy Lee, who's a neuro-ophthalmologist who was at Iowa. He's now the chair at Methodist. And this is what he calls a sandwich approach. And this is how he gives feedback to his residents. And he calls it the sandwich. So normally he starts with the bread and he tells all the positive things. So for example, you're a good resident, you're here on time, and then he tells the meat, which is all the bad the bad feedback. Well, you're not a great surgeon, you're a slacker, you don't work fast. And then he ends with the good. He ends with good positive feedback in the end. But I know you're going to be a great doctor in the end. So the same type of sandwich feedback for the presbyopia correcting lenses. I start with the bread. So I say most people will achieve uncorrected vision with these lenses. They're good. And then I spend a lot of time on the meat, which is all the negatives. You might get glare and halos, you might have an unpredictable outcome. And then I end with the good, in that most people, 95% of the time, people are very happy. So it's a nice way to present all the material, but end on a very positive note. The other last thing that I did that has really changed my outcomes with the happiness factor is on post-op day 1, I have this single sheet of paper that I give to patients. And I give them to it on post-op day 1. I don't give it ahead of time because before surgery, they have so much information thrown at them that they won't remember. So on post-op day 1, you have their undivided attention. And I tell them in big block letters that they are going to have halos and glare. Their vision is going to fluctuate. It's going to maybe take months to stabilize. They're probably going to need both eyes to have the perfect outcome, and that artificial lenses are artificial. And the reason I do that is many patients are they're worried after surgery, or they're suspicious that something went wrong when their vision isn't perfect. And so they go home and they think about it and they think something's wrong. The doctor put in the wrong lens, this isn't working. But if they actually have a piece of paper that actually says that this is normal, this is what you're going to expect, they feel much better and they feel like, oh, you know what? This is okay, this is normal. So now if I ask the patients, are you having glare and halos, Mrs. Smith? They'll say, oh yeah, you told me I was going to have glare and halos, so that's fine, I know the lens is working. So the patients seem to be a lot more comfortable after surgery. So in summary, I think it's really important to make sure that you have a game plan going forward, have a very thorough exam, have a stepwise approach so you know exactly what you're recommending and why you're recommending it in that order. All right, so those are the first two talks combined, and I'm going to just go ahead onto the last talk, and that's for the toric pearls. Thank you. And I know we're running behind a little bit, so I won't ask for questions, and then afterwards, I think when we have the break, we can do that. So if we can have the pearls for toric, thank you very much. All right, so, thank you. All right, so it sounds like most everyone here uses toric intraocular lenses, I believe. And I think the trickiest part is when people come back and the toric has rotated. So I wanted to present a couple little things about what I've learned along the way. So here's a case. This is a 79-year-old man who was referred to me for a second opinion. He had cataract surgery 3 months ago with a toric lens, and he complains of blurry vision and halos. He has a history of glaucoma, and these are the current meds. So he's still on prednisone and acetate 1% 4 times a day. He's on some glaucoma medications, and he's on a non-steroidal 3 times a day. This is vision. It's 2200 uncorrected, pinhole to 20/60. And his manifest, he still has a little bit of myopia. He has some cylinder, and this yields about 20/60. His pupils are normal, pressure is okay, and his slit lamp, this is his slit lamp exam. So if you look really closely, you'll see that there indeed is a toric lens, and you see that it's a one-piece acrylic toric lens, and you can see the little hatch marks, the little dots on the bottom. But if you look really, really closely, you'll notice that the inferior haptic is not in the bag, it's in the sulcus. So the superior haptic is in the capsular bag, and the inferior haptic is now in the sulcus. So hopefully everybody knows that one-piece acrylic lenses cannot stay in the sulcus. They do cause a lot of irritation and rubbing, and therefore they cause inflammation long term. So that could be causing some of the trouble. So when you look at the slit lamp, indeed he does have 1+ cells in the anterior chamber. You see where the toric marks are, and you notice that His inferior haptic is in the sulcus. His optic nerves are a little asymmetric from the glaucoma. He also has some dry AMD, so his potential vision probably is only around 20/60 because of his macula. Fortunately, his fluorescein angiogram looks okay with no CME. So the question is, what do you do at this point? So we know that the haptic probably has to go back into the bag, but he also has a toric lens. So the question is, where are you going to put that toric lens? He's a -1 with -1 diopter of cylinder left. So you can either, if his haptic did not have to move, one of the options is you could do a corneal laser refractive procedure. A lot of surgeons would prefer to alter the cornea rather than to go in for the IOL. I find that if the primary surgery is fairly recent, less than 6 months, even up to a year, it's fairly easy to do an IOL rotation. So I always prefer to go back into the eye to change the IOL rather than go ahead and change the cornea. If it's greater than 6 months, it's a little bit more difficult. I still think it's possible. And if it's over a year, oftentimes a lot of people would just rather treat the cornea. So here is the IOL master printout from this particular patient. You'll notice that there is an error here. And it looks like the technician has put in pseudophakic silicone. And those are little things that you should keep in mind is when they do rerun the IOL master, you want to make sure that you are making sure every factor is perfect. But what I want to show is the difference in Ks. So you'll see that the IOL master shows that it's steep at 96 degrees, and there's about 1.75 diopters of cylinder in the cornea. And here's the topography. And fortunately, the topography is similar. The axis here is 102. And here are the other Ks. So the IOL master Ks, it's steep at 96. The topography 102, manual K is 100, auto K is 101. And fortunately, the axis is fairly similar, but the amount of K is a little bit different. The original corneal incision is at 180 degrees. So again, a question may be, are you going to enter in the original corneal incision, or are you going to make a new corneal incision? And it all depends on how long ago the original surgery was. So since the original surgery is only 3 months, it's pretty easy to go back into that clear corneal incision. It's actually surprisingly easy to enter into that corneal incision. You just break the epithelial seal, and with a blunt instrument, you can just go in and dissect out the corneal incision very, very readily. So I always tend to enter in the original incision if I can. That way you don't induce another factor that may cause astigmatism. A nice tool is astigmatismfix.com. This was created by John Berdahl and David Harden, and they put together this wonderful website where you can just input the power of the toric, the axis location, and the manifest refraction, and it tells you the amount of rotation. So here's a screenshot. So you put in the information, so you put in the manifest refraction of the current refraction, you put in what toric power was placed, and you put in the axis, and it tells you exactly where to rotate it. It'll say rotate the IOL 20 degrees to this particular axis, and this is what the residual cylinder will be. So astigmatismfix.com, very, very easy to use. This is also another nice tool, is the NIDAC OPD3. You can actually have a retroillumination screen where you actually dilate the pupil and you take an image, and you can see where the toric IOL is, and it overlays where the steep IOL is. So you can actually move the axis to tell you exactly how many degrees, and you can tell by this particular lens, it's 37 degrees off. So it tells you exactly where it is off compared to the corneal curvature right there in the clinic. So these are nice tools. You've heard a lot about Aura, so I won't belabor the point. I do think that the Aura, the intraoperative aberrometer, has been a really, really wonderful new technology that's really come in handy, and especially for cases like this where you're going in and you're trying to fine-tune that position because they already had a rotation already. It's been very, very useful. The screenshots, I won't go through this since you've already seen a wonderful presentation. This is the money slide. You always are very happy when you see this no rotation recommended. You know that the lens is in the right place. You're happy and you can leave the eye. All right, oh, let me go back. All right, so if you will play that video, hopefully. Maybe. So this is a video of, great. So this is the video of rotating that lens back into the back. So a couple key tips. Very important to dissect out that lens with a lot of viscoelastic. I'll tend to use a dispersive viscoelastic like Visco. And since this is a Alcon toric lens, I know that the terminal bulbs at the end of the haptic can get a little stickier. I make sure that I dissect out both haptics, and I want to make sure that it's freely mobile before I rotate it. This lens, it's only been 3 months, so fortunately it moves pretty well, but you'll see that I'm going ahead and dissecting with the viscoat. If it's been a long time since a primary surgery, it may be difficult to get underneath the leaflet, so using a sharp 30 gauge needle to lift the leaflet and then switching over to a blunt cannula is a good idea. I tend to use both hands where I'm rotating one and I'm actually pushing the haptic with another, so I can gently go ahead and bring the haptic back into the capsular bag, and then I will go ahead and rotate it and make sure that it's actually seated in the proper position. Again, because I use the intraoperative aperometer, you'll see that I don't have a lot of marks on the cornea because I will just do a fresh reading of the eye. The systems like Varian or the Callistos are very, very helpful to correlate what you see in the clinic preoperatively to what is happening on the eye, because you can match up things like the scleral vessels, you can match up the iris features, and that helps align so you don't have to worry about cyclorotation. So post-op, this patient, his cylinder was resolved. He did have some sphere, so that IOL power was off a bit. We had already talked to him ahead of time, and he did not mind being a little myopic, especially since his AMD, his best vision was 20/60. So we decided not to do an IOL exchange. We just wanted to rotate the haptic back in. So in summary, I think that when you have a surprise, especially with a toric lens, you want to make sure that you're remeasuring everything. And oftentimes, if a toric rotation is going to occur, the literature shows that it's going to occur in the first week. It's very unusual that it happens much later than that. So if it's been more than a week, usually you're pretty good in terms of the toric rotating. Remember to use astigmatismfix.com. I think it's a very useful website. Thank you very much.